Blah, blah, blah. And the punchline is. Hello, hello, hello. Okay. Yes, I do that sometimes. Ooh. Yeah, maybe. Quite funny. Natalie has infected you. Yeah. That's everybody. Are there any more tests? Tests, quizzes? All right, I have a handout for you that will list the drugs we will cover today. So we have the drugs that inhibit this coagulation pathway. You three, okay. Irish? Yeah, that's Gaelic. That'd be the Gaelic pronunciation. Yeah. Very good. All right. So if we look at the pathway for coagulation, remember, this will form those stiff cable-like proteins that reinforce the platelet plug. Some of the drugs will inhibit activation of platelets. Others will prevent the formation of that stiff cable-like protein that reinforces the platelet plug. There are two ways to get to the fibrin polymer. There's the extrinsic pathway and the intrinsic pathway. The extrinsic pathway is relatively straightforward. Tissue factor that's liberated when tissues or their capillary beds are damaged. You liberate soluble tissue factor or tissue thromboplastin, it's called both, into the blood that binds with soluble factor 7, that activates factor 7. Factor 7 then, in complex with things like calcium and phospholipids and things like that, will activate factor 10 by proteolytically cleaving it. Factor 10, you clip the front off, now you have active factor 10. These clotting factors are members of a large protease family called the serine proteases. The serine proteases. In fact, trypsin, chymotrypsin in your GI tract, your duodenum, secreted by the pancreas, they are also serine proteases. So the serine protease family is a very, very, very large family of proteases. Clotting factors are members of this venerable family of proteases. So they tend to be made as inactive precursors called zymogens. When you clip them, cleave them into their smaller form, that smaller form is the active form. Factor 10 then goes on to take prothrombin, clip the front off you make thrombin. And thrombin will take fibrinogen. Fibrinogen is made by the liver. It's 4% of the blood protein, quite a bit of it in blood. You clip pieces off fibrinogen, it will now self-assemble. It's now fibrin, it self-assembles into this long, stiff, rod-like polymer. Those polymers are cross-linked by something called factor 13. Factor 13 works slowly. This is what we call curing of a clot. It becomes cross-linked, less soluble, tougher. That is the extrinsic pathway, relatively straightforward. Intrinsic pathway, right bit more complicated. You activate factor 12, the activation of factor 12, not quite as straightforward as it looks here. Instead, when you have a breach in the blood vessel, you have a protein that's called prekallikrein. Kallikrein will stick to a negatively charged surface and it's able to cleave itself. So now you get kallikrein. Kallikrein can take factor 12 and can activate factor 12. Factor 12 has an ability to activate itself when it sticks to negatively charged surfaces, glass, collagen, things like that. That's why if you draw blood and put it in a glass test tube, it's going to clot. Because you've given it a negatively charged surface for the intrinsic pathway to start working. Factor 12 co-activates itself very poorly. Because it co-activates itself very poorly, it gets a little help from its friends. Its friend is kallikrein. Kallikrein will take factor 12 and will convert it to the activator. Factor 12 will then activate factor 11. 11 activates factor 9. 9 in cahoots with factor 8. And phospholipids and calcium and blah, 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 they will cleave factor 10 to the active form. And then the 10 to thrombin to fibrinogen, that pathway, so-called common pathway. So that's used by both the extrinsic and intrinsic pathway. So where can you attack the problem of clotting? If you have someone with blood vessels that are beat up, they're throwing clots, they can get a heart attack or a PE or a stroke or something like that. Do you know what PE means? Thank you. Pulmonary embolism. Pulmonary, as not physical education, pulmonary embolism. You get a clot in the lungs. It's very dangerous. How do you inhibit clotting? There's several ways to address the problem. You can inhibit thrombin directly. And there's a drug that does that, and that drug is called dabigatran. Dabigatran. Goes by the trade name Produxa. Dabigatran will bind to thrombin and cut it off the knees. No longer works. You can also address this at the level of factor 10. And you have several drugs that are oral, anticoagulants. Notice they all end in XA-BAM. XA-BAM. In other words, activated factor 10, BAM. That's how you remember them. They ban active factor 10. So look at this with me. There's rivaroxaban, apixaban, edoxaban, betrixaban, and then the oddball there, which is not oral, is given intravenously, is fondaparinux. So those 4 XA-BAN drugs are all new oral anticoagulants, the NOACs, new oral anticoagulants. The other place where you can attack this problem is by using a complex carbohydrate that will bind very tightly to antithrombin 3 and activates it. And that complex carbohydrate is heparin. You guys will use a lot of heparin in your careers. Trust me on that one. So it behooves you to know heparin like the back of your glorious hand. And we'll get to heparin. We'll talk a good deal about it. But heparin comes in 2 flavors. There's unfractionated heparin, whose pharmacokinetics are not so predictable, but it's very cheap. Then there is low molecular weight heparin, which is a synthetic product, a little bit more expensive, but has very predictable pharmacokinetics. You will almost certainly use both in your careers. UF, unfractionated heparin, and LMW, low molecular weight heparin. And they work slightly differently. Then finally, there is ye holy pain in the butt drug, warfarin. Here's how warfarin works. Clotting factors 2, 7, 9, and 10. I will repeat that. Clotting factors 2, 7, 9, and 10 must go through the liver after they're made and be post-translationally modified. How are they modified? Their glutamic acid residues are converted into gamma carboxy glutamyl residues. Now, what on earth does that mean? You put an extra carboxyl group on the glutamates. So now you have this carbon with 2 carboxyl groups hanging off like that. Now, carboxyl groups are negatively charged. So you made this molecule, you make this little pocket that's perfect for binding calcium. To convert these enzymes, these proteins, into things that bind calcium prodigiously. In fact, they have to be able to bind calcium to be able to be active. This post-translational modification is vitamin K dependent. It's vitamin K dependent. Warfarin is a vitamin K antagonist. It's a vitamin K antagonist. So you give warfarin. Warfarin takes about 4 days to start working. You always have to bridge someone with another anticoagulant, usually heparin is what you use. Warfarin interacts with a truckload of drugs. It interacts with lots of foods. Its half-life varies from person to person and from which way the wind blows. Why do we still use it? Because it's dirt cheap. A month's supply of warfarin is less than a penny a pill. It's extremely inexpensive. That's why it's still used. But it's a pain. You have to constantly monitor someone's coagulation when they're on warfarin. Every week. Oh, that sounds like a pain. You think? That's why folks are trying to move to the new oral anticoagulants because they don't have to be monitored. Warfarin has to be monitored constantly. So those are your arrows in your quiver for anticoagulants. Now, anticoagulants are used to address clots in veins. They're used to address clots in veins. Yeah, not anticoagulants used to address clots in. They used to address clots in. Claire, they used to address clots in. Thank you. Natalie, they used to address clots in. Please don't forget that. Please, oh, please, oh, please, oh, please don't forget that. Write it on your 3x5 card, put it on your mirror. So you can look at it every day when you get ready in the morning. You have to. Don't forget that. That's your memory verse for the night. Anticoagulants address clots in veins. Thank you. Veins. Antiplatelets. Drugs that affect platelet stickiness address clots in arteries. Clots in arteries. And we have several of those, and we'll get to those in just a bit. Let's soldier on here. First, let me stop and see if there are any questions. But then, yeah, McKenna?
Is it warfarin that has an interaction with aspirin?
And 500 other drugs, yeah. Warfarin is a pain. It is. It's a pain. You have to look up All the other drugs the patient is on, you'll have to dose them up or down, depending on what drugs they're on. And then if their diet changes, you'll need to also adjust their warfarin. If they go out to a restaurant and they have a bunch of vitamin K containing food at the restaurant, you're going to have to adjust their warfarin. Stop with the scam calls. God, who is these people? Should be lined up against a wall and shot. They've called me like 20 times today. Leave me alone. I did, and then they find another number from which to call me. It comes from the same place. Jiminy Crickets, can't you guys take a hint?
There's a way to have your phone that, because my phone, it'll silence all calls that are like that, and it says potential spam, so it doesn't.
Yeah, that's how I know it's spam. But it still buzzes here and here, and I'm just like, stop.
Yeah, mine's
Enough.
silent.
After a while, it just really gets you. Okay, I'm good. All right, and Will Smith slapped Chris Rock. Okay, yeah. That's the only thing on the internet now is Will Smith slapped Chris Rock. It's everywhere. Can we talk about something else for change? Okay. Now, if you have a clot that's up against a endothelial cell, then endothelial cell has receptors for fibrin, and it activates the endothelial cell to start to secrete this molecule called tissue plasminogen activator, which is a protease. Tissue plasminogen activator, which goes by the trade name TPA, is going to cleave a very powerful protease in the blood called plasminogen. And it now becomes plasmin. Plasmin dissolves clots. That's why clots are not eternal in your body. They get dealt with. Now, there's another enzyme as well that can activate plasmin called urokinase. Plasmin tends to be found inside the blood vessel. Urokinase tends to be found outside blood vessels. So genetically engineered TPA is actually used to break up clots inside your body. We're going to get to those. Those are the so-called fibrinolytics that are used to get rid of clots. Now, let's say you are drawing blood. Now, when you draw blood, you have tubes, and those tubes are different colored tops. You have to draw them in a certain order. If you don't, you're going to contaminate things in one tube that shouldn't be contaminated by the other. So you do the blood culture first, you do the light blue colored tube next, you do the red colored tube next, and so on and so forth. And you'll learn about all that in fundamentals. Did I learn about that? No? Med-surg? Work? You learned it at work. Okay. Well, you'll learn it somewhere. Okay. Oh, okay. Anyway, some of these tubes, you want the blood to clot. Some of them you don't. How do you keep blood from clotting? There's two main ways you keep blood from clotting. First, you can use sodium citrate. Sodium citrate is a salt that's very inexpensive, and it grabs calcium. No calcium, no clotting. You can also use a salt called EDTA, which is ethylene diamine tetraacetate. Let's just call it EDTA, okay? Deal? And EDTA also grabs calcium. No calcium, no clotting. So these are direct clotting, anti-clotting things because they strip calcium away, and calcium is really important when it comes to clotting. So that's already going to prevent clotting in test tubes. Sometimes you want the blood to clot, you want the serum free of clotting factors. Other times you don't want it to clot. That's how your tubes are going to prevent it from clotting. That's why you have to keep the draw in the right order. So when you learn this order of draws, which tube to fill up in which order, pay attention to it and follow it all the time. That's the other piece. I don't want to go into that because you'll learn that in other classes. All right. Let's talk about thrombosis. It's very hard to know how many cases of deep vein thrombosis there are in the US per year. CDC says around 900,000, but the CDC admits that's a very low estimate. WHO says that the venous thromboembolism, that worldwide there's about 10 million cases. That's even probably a low estimate. So WHO using an algorithm says that there's probably just over 2.5 million cases in the US. That's probably high. There's about over 500,000 cases of pulmonary embolism. Do you guys know the difference between a thrombus and an embolism? Yes. You're right. Sorry? Yes. Thrombus forms in place. If it breaks off and floats through your circulation and gets stuck someplace else, that's an embolism. Thrombus in place, embolism goes elsewhere. So of these over 500,000 cases of PE, 50,000 of those, over 50,000 of those, probably more like 100,000 of those cause death. And then pulmonary embolisms contribute another 150,000 deaths or so per year. And of the post-surgical deaths that are due to PE, it's about 11,000. Can we agree this is a significant problem? So what kind of indications are there for antithrombotic therapy? You can read the list. Basically, anytime somebody has a condition that causes blood to pool. When blood pools in your body, it clots. That's why things like atrial fibrillation will require antithrombotic therapy. The atria aren't working properly. Blood pools in the atria, particularly in the atrial appendages. You form clots. Those clots then can launch anywhere in your body. They can cause a stroke. They can cause a deep vein thrombosis. They can cause a heart attack. They can cause all kinds of things. Also, if you have conditions that provide surfaces where clots can form, so artificial heart valves, any sort of joint implants that aren't covered by membrane. So when somebody first gets a joint implant, they have to be on antithrombotic therapy until it heals properly. If they have messed up valves that are roughened, clots can form there too. It's any of these essentially are going to be indications for antithrombotic therapy. Vascular grafts, shunts, bypasses, stents, at least when you first put them in before you get growth all around them. All of those essentially are indications for antithrombotic therapy. So this just illustrates that you have the two parts of clotting you're going to attack one or the other. It depends where you're trying to prevent clots from happening. So you want to try and reduce the risk of vascular injury. You want to try to reduce platelet adherence and activation. That's what your platelet inhibitors will do. To reduce thrombin generation, fibrin generation, use anticoagulants. And if you get a clot in place, you want to break it up, you use fibrinolytics. Been there already. I don't want to belabor this point. Just show it up there again to remind you this is what we're attacking, if you will. So essentially up there, you have fibrinogen. So thrombin, as you see, is going to trim that central piece. It's going to give that central piece a haircut. When it gives that central piece a haircut, this thrombin protein can assemble. They essentially assemble just off each other like that, and they have an affinity for each other. So the big dumbbell piece has an affinity for the middle piece, and it self-assembles into a polymer. Over time, it gets cross-linked by factor 11. Plasmin will come in and degrade this. As it degrades it, it will generate something called D-dimer. D-dimers, because these pieces here aren't degraded very well by plasmin. D-dimer is an excellent marker in the blood for whether or not someone has had a clot. So remember that blood marker, D-dimer. That's not the only blood marker we'll look at, but that's an important one, D-dimer. Now here's how you're going to stratify people for their risk of a clot, and this will determine whether or not they should go on a thrombolytic. So this is called the Chad-Vask score. Chad-Vask score. All of these factors here, do they have congestive heart failure? Do they have hypertension? Are they older than 75 years old? Do they have diabetes mellitus? Have they had a stroke or transischemic attack? Do they have vascular disease, either peripheral arterial disease, aortic plaque, prior myocardial infarction? Are they aged 65 to 74? And are they female? You get points essentially for each of these that you have. If your score is 0, you don't need to be on anything. If your score is 1, then depending on other factors, you might not need anything, or you may just need a baby aspirin every day. Some people may say, some of these are a little bit borderline, maybe I'll put you on a low dose oral anticoagulant. If your score is 2 or more, you're a candidate for an oral anticoagulant. Chad-Vask score, the Chad-Vask score. Now, how do we stratify risk using the Chad-Vask score? Using the score, you can show the increased risk of stroke. And you can see it will go up incrementally as you accumulate more of the Chad-Vask items, if you will. To where if you get 9, essentially, your risk for stroke now is increased by 15%. They can agree that's pretty significant. So plasminogen is converted to plasmin. Plasmin, there are some surface molecules that inhibit plasmin and kind of hold it in check. You produce these fibrin degradation products, of which D-dimer is the most informative. If you look at the fibrinolytics, they're on the back page of your handout. These will come as powders. You make up the powder My understanding of the law in Michigan is that nurses are not allowed to compound. Is that right? Yeah. So the pharmacist will have to compound this for you. If you are a nurse anesthetist, you can compound certain types of drugs, propofol, things like that, what have you. So the pharmacist will compound this for you. And there's 3 of these. There's Alteplase, goes by the trade name Activase. This is the one with the shortest half-life. This is the one that's the oldest of the drugs, and there's the most data on this drug. Alteplase is used for heart attacks, and it's used for strokes. And it's also used for pulmonary embolisms. It's the only one that's also used for strokes and pulmonary embolisms. These other 2 are genetically engineered TPAs that have a longer half-life and are more active. They're not as old as Alteplase, so there's less data on them. Therefore, they are only approved by the FDA for acute myocardial infarctions. So there's Retaplase, also known as Retavase. This one, as you can see, is about 3 times longer half-life than Alteplase. And then there's Tenecteplase, which goes by the amusing trade name of TNCase. Tenecteplase, as you see, has a formidable half-life. And it is also used to clear hemodialysis catheters. That's its main use, frankly. But it is also used for acute myocardial infarctions. There are protocols for these drugs. Your lines have to be washed, have to be flushed pretty well before you use them. You will be trained on the use of these drugs, and when the patient's on them, you have to watch them. Because if the patient starts to, the big risk of these drugs, of course, is clots get dissolved, so they start to bleed. And say you're trying to treat a stroke, if they start to bleed intracranially, that of course is very bad. If they start to show signs of increased intracranial pressure, you pull the drug ASAP. Thrombin is also an activator of platelets. So thrombin not only is going to participate in the formation of fibrin polymers, there is also a receptor on the surface of platelets for thrombin. And when thrombin binds it, it helps activate the platelets. And this receptor is called the PAR receptor, PAR. We will come back to this because this is actually a target for a certain antiplatelet drug. We talked about these before. Again, these are just ways essentially that the body can regulate anticoagulation. Then there are things that prevent platelets from getting sticky, prostacyclin, nitric oxide, and then so-called clot busters and what have you. All right, let's go to heparin. Unfractionated heparin is a heterogeneous polymer, as you can see. The way it's isolated, you get a mixture of different polysaccharides. Some are kind of short, some are really long. It binds to antithrombin 3. When it binds to antithrombin 3, it hyperactivates it. And it binds to thrombin and inactivates it. The shorter polymers in heparin can't interact with antithrombin 3. They inhibit factor 10. So with heparin, you kind of get a twofold inhibition. You inhibit factor 10 and you inhibit thrombin. So it's just a polymer of this negatively charged polysaccharide. So this 5 sugar polymer just repeats over and over and over and over again. That's heparin. It binds to antithrombin 3. Antithrombin 3 then goes on a tear and grabs up all the thrombin and inhibits it. And antithrombin 3 can also inhibit several other things too. So when heparin activates antithrombin 3, it pretty much shuts clotting down. That's the long and the short of this. All right, now heparin, unfractionated heparin, has a very good antidote, and it's called protamine sulfate. Heparin's really negatively charged. This is really positively charged. It's a match made in the blood vessel, and they go, and they never let go. Just kind of gets you right there. Yeah, especially if you're having a heart attack. And heparin is completely inactivated. Protamine sulfate inactivates unfractionated heparin in a 1-to-1 ratio. So you know exactly how much protamine sulfate to give, and it inactivates it quickly. That's the beauty of unfractionated heparin. Protamine sulfate is administered via IV. It's administered slowly. Slowly. No faster than 20 milligrams per minute. Never exceed 100 milligrams in a 2-hour period. Don't overdo protamine sulfate. If you do, yeah, the patient runs a risk for excessive anticoagulation. Now, unfractionated heparin has this advantage. It is easily and quickly reversed by protamine sulfate. Also, it is not renally eliminated. So you can give it to people with bad kidneys. That's the other advantage of unfractionated heparin. Now, the downside is its pharmacokinetics ain't so predictable. So you're going to have to do a test to determine how well it's working. The test you're going to order is the activated partial thromboplastin test. The PTT or APTT is used for heparin. PTT test is used for heparin. I want you to know this. That number that you see on a test is for heparin. Don't use it if someone's on warfarin. It's the wrong test. It's used for patients on heparin. I don't think you believe me. I think you need to say that a little louder. Heparin. Thank you. Heparin. Very important. Heparin. Unfractionated heparin has a shorter half-life. It also prevents the formation of clots in stents, catheters, and any sort of extracorporeal circuits. That's why it's still used. Now, the child, if you will, of unfractionated heparin is low molecular weight heparin. Low molecular weight heparin is all short polymers, so it is molecularly homogeneous. Its pharmacokinetics are very predictable, so you don't need to do activated partial thromboplastin tests on it. Has a longer half-life. This does not activate antithrombin 3. Instead, it inhibits factor 10 because it doesn't have the long polymers that bind to antithrombin 3. You can also send these bottles of low molecular weight heparin home with people who say just had a knee replacement, and you teach them how to inject it sub-Q. And they can give themselves injections of it. Pretty easy to do. And that, as a nurse, will be one of your jobs. It's teaching people how to inject various things sub-Q. So it behooves you to get very good at learning how to do sub-Q injections. So here are the three main products. The one that's used the most is this one over here. Enoxaparin, goes by the trade name Lovenox. Lovenox. The other two are still made in the US. I looked them up, made sure. They are still manufactured. Although Tinzaparin, my understanding is that the manufacturer is going to stop making that by the end of the year. So Tinzaparin you won't be able to find anymore. By the time you guys start working, it won't exist anymore. So if you want, as you're looking at this slide, just in your head, just go X. It's just not going to exist. Definitely enoxaparin is the one that is used the most. Some people can have hypersensitivity reactions to low molecular weight heparin. If they do, they'll have chills, fever, and urticaria, otherwise known as a rash, or hives, rather, excuse me. So how are you going to determine if someone's hypersensitive to low molecular weight heparin before you give them a package of bottles to take home? McKenna, you're so smart. Yes, exactly right. You do a small dose administration and you watch it. If you get a wheel and flare, bad news. Bad news. The beauty of low molecular weight heparin is its longer half-life. Don't have to dose it as often. Because it binds less to platelets and plasma protein, it has greater bioavailability. Therefore, you just get, in general, a more predictable anticoagulant response with low molecular weight heparin. That's why it's used so much. It's safe. It both prevents and treats venous thromboembolism. And you guys will use it a whole lot. guaranteed. I believe we're due for a break. Yes? Right, go ahead, take 5. Claire, where did you work? Where do you work? You're a student nurse or?
I'm a nurse actually. So it's like a little bit of a tech.
Okay. Just.
17, 9.
You're still young or something.
No,
Wow.
I think you just have to have your like foundations to be able to apply, but they prefer it when you're close to graduation. So I sort of
What sort of things can you, well, obviously administering medication.
I don't administer medication. I don't do that in like the student nurses. That's like the one thing I don't think I do.
Yeah.
Blood draws I can do. I can actually do indwelling and straight casts. So but I do like patient care, I do blood sugars, I do IVs, I do blood draws, I do blood cultures. I do like regular patient care, vitals, and all that stuff. I can do NG tubes. There's a lot. Yeah, okay. Both of the indwelling holding. Yeah, I can help suction and stuff, but I can't like I'm just really not like for while I'm there. But
Okay.
yeah.
I read that NPs, some NPs are
Mhm. Yeah.
That's good money.
Yeah, there's not a lot of job open for NPs. I mean, I know that's why I do that.
And the mental health ones, you
I like
get more
medications.
responsibility because of the shortage of psychiatrists.
Yeah, I like the medications to be easy.
Yeah.
They're pretty easy. The one thing though is with the NPs, you have to know how the chemical reactions to all the medications.
Yeah.
Which is one thing. I recommend the extra. I just have a lot of patients. So I have like 11, 22 patients. I'm only supposed to have 7.
Do you stay in one department or do you float?
I can float, but I'm usually between 17 and 16. So I'm on a neuro ICU and I get a lot of strokes and then
Close head injury, that sort of thing?
we don't have a lot of head injuries. Honestly, we just have a lot of strokes. Strokes, or then sometimes they give us like back surgery patients that are more like high level of care, we have more comorbidities and all that stuff. So we have
Well, you guys are filtering through things. A tradition I have in this class, since it's coming up, after we take our final, which the final will be the evening of that Wednesday of finals week, I usually have the class over at my house, which is in walking distance, for a I Survive Pharmacology shindig. So we will provide the victuals. If you guys want to bring something to drink, that's fine. Last year, I think well, let me give credit where credit's due. My wife made hot wings and meatballs and stuff, and it was very fun. We had a lot of fun. And the year before that, the weather was nice. We were able to do it outside. I know that's finals week. I know you guys are wanting to probably get back and study, but after my final, I'm guessing you might want to let your hair down just a tad and rest a bit. So Maddie, your husband's invited if he can come. So significant others of that sort are definitely invited. McKenna, Michael's invited. So please put that on your calendars and be thinking about that. I'll give you directions to my house. You can walk there in 10 minutes. Well, not even 10 minutes, 5 minutes. So please come. I'd like to have as many of you come as possible. And we'll celebrate that you survived farm. And yeah. I will open up the discussion board for questions. The final will probably be on, Mindy wants me to do on an ATI. Oh, I need to talk about ATI as well. Thank you for reminding me. It in the past has worked to just do it on Blackboard, but and it's worked quite well on Blackboard. Okay, ATI, the Proctorio. When I did the proctoring tutorial, it didn't say anything about me having to be there while Proctorio was doing its thing. So that means I have to be available while you guys are taking it and Proctorio is watching you. So the best times for me are Tuesdays and Thursdays in the afternoon. So if I said, well, let's have say 2 o'clock to 4 o'clock Tuesday, 2 o'clock to 4 o'clock Thursday, and then maybe on Friday as well, after my 3:30 class, we could do it either later that day or maybe, no, I could do it earlier probably before 1:30 class. Yeah, so we could do it earlier on Friday as well. So we could do Tuesday in the afternoon, Thursday in the afternoon, Friday, probably morning to early afternoon, something like that. And then Mindy Rice, Dr. Rice said she would stand in, and I need to find out when she's available. But when she gives me her times, she teaches apparently once on Monday, and then after that, she's largely available. So she will give you some times, and then you guys can just pick a time essentially to take the quiz. Yes. Proctorio, if you're looking around at other things beside the screen, Proctorio will flag you and it'll tell me. And Proctorio, my understanding of Proctorio from the tutorial I took, if you look down away from the screen, Proctorio will flag you. If your dog comes in and starts wanting to jump on your lap and you look down at your dog, Proctorio will flag you. So if you have your notes out and stuff like that, Proctorio is going to be going nuts. So I'd rather you not. Now, looking down, I know some of you look down when you're thinking. Natalie, you do that. You sometimes will look down when you're thinking. And Proctorio would flag you sometimes for that. It'll flag you. You're supposed to be looking at the screen, and you're supposed to be kind of, if you look away, the video detects a change in attitude of your eyes, and I get a message saying, Natalie looked away from the screen, which part of me says, yeah, big hairy deal. Now, if you try to get out of the program and go search online or something like that, it locks your test. Yes. Yes, but if I want to be doing something else like writing tests or something like that, I won't be looking at the screen all that much, but I'll get a message that says, better watch that Macy. She's counting tiles or something like that, which maybe Macy's admiring all the beadboard work she did in her room or something. I don't know. So Rebecca, I rather you not. That way it keeps the disturbances to a minimum. Now, we did talk about Meg does this in other classes. You guys will have Meg. Meg is our, you've had Meg for several classes probably. Meg is our ATI guru because she's really familiar with the system. Meg does these makeup tests. If you tank the first test, she does a little makeup and you can take that to kind of make it up and get a better score, which I'm happy to do. But let's see how you do first before we talk about remediating tests and stuff like that. So, all right, so I will, yeah, Natalie? Right, so I'm thinking like 11:30 to 12:30, something like that. Okay.
All the other things on each side, do you have to do all those, or are we just doing the sections that say like the
Proctored, the ones that say proctored.
Oh, I'm saying like, so if I go into it says the dosage calculations, engage fundamentals, becoming a professional nurse.
The dosage calculation is not proctored, it's a print. It's printed.
So we don't have to do those?
You don't have to do that on ATI. I'll pass that out to you when I'm good and ready to.
Okay.
If there are assessments that are assigned to you, yes. And I did all the assessments for the modules, so they should all be there. Yes.
On the ATI test, will they give you the answers?
After you're done, you get a score. It doesn't tell you the answers unless I give you the answers. I can print out the answers or I can make the answers available to you, which I've chosen not to do because you haven't taken the test yet. So it'd be pretty dumb for me to say, oh, this is an evaluation, you're gonna be great on this and give you the answers. So there's a link that I can click on that says provide answers. And after everyone's taken it, yeah, I'll do that. So, yes. Oh, good golly, I can't see that far.
And these are all our modules,
Uh-huh.
and then we have to take the test and stuff. So it says like 89% complete because like I was supposed to be like time limit. So you're supposed to spend like 60 minutes reviewing.
Yeah,
the
if you're inactive for a period of time, it logs you out.
No, it says like you have to finish, like you should take a minimum of 60 minutes for the lesson. Like I finished the lesson in 40 minutes, so it doesn't say I'm 100% complete.
And same with the test. If you get
If you
100%
don't-
on the test, you don't get the 25
minute, it marks you down.
Even if you get 100.
That's, you're not being graded on that, so don't worry about that. So,
Are we just using the pharmacology to make it easy to study for the part?
Yeah. Yeah.
So all the tests. And
Yeah.
all those great stuff.
So ATI, the test banks in ATI are former NCLEX questions. So they're getting you used to the NCLEX format. And all our experience with ATI so far says it's an excellent product for preparing students for the NCLEX. So that's why I'm an advocate, even though it's more expensive, of getting students exposed to ATI earlier and earlier in their nursing education. Now, we've changed it so that you all don't matriculate to the program until after this year. So that's why we had to do the rigmarole of you guys essentially getting onto ATI because ATI didn't think you guys would need to have an account until next year. But by getting you onto ATI earlier, you get more used to the system, you get more used to NCLEX type questions. And when it comes time to take the NCLEX, you're golden. Because we've had very good success with the NCLEX so far. And I think it's largely due to ATI. So ATI is your friend, even though it doesn't seem like it sometimes. But those questions, Rebecca, I think it was you asked me about taking the questions out, putting them on Blackboard. You can't do that. If you try to cut and paste them and put them something else, the system doesn't let you do that because those are ATI's intellectual property. They don't want you, they want you doing stuff on their site for which you have an account for which you paid for, which is fine. So, question? Yeah.
So for the proctored ATI exam, what are you saying that we're gonna do that? Like just a random Friday?
Well, every Friday. I would do it every Friday.
We're doing it every Friday? Or are you giving us?
No, it's available. You pick a time when you're available. And I open it essentially with students and say, I want to take it. I let them in and then I click take test and then, so you just pick a time to take it. And
Well, does it give us an email to like schedule time? Or like
yeah, I
just,
can do
like,
that.
place
Or I
on
can
the
post
time?
them on announcements on Blackboard site. Yeah.
And then our,
Ooh, you know, are you gonna have a problem because you're not part of a cohort?
yeah,
You're part of a different
I
cohort.
won't show up online. So they'll have to switch me over the day that I pick.
Meg said there's a way to fix that.
I have no idea. It would
Yeah.
be nice if send a complete task. 'cause I
Meg
said
said there's a way you could be like a visitor.
to yours.
I've talked to Meg. I've talked to
Okay,
Meg.
yeah,
Meg-
because I would like to start doing my easy.
Meg's the guru
Because if
on
it's like
this.
20, isn't
Do you
it-
have a class with Meg this semester?
Yeah, I have. next
Can you
week.
ask her about that? Because she's the one who switched you
Yeah.
over.
It won't be till next week though. So that's
Okay. See if Meg's got, because Meg knows everything about the ATI. It seems.
If I can't access the test, are we gonna do printouts?
Yeah, we can, for you then, we can do a printout and you can do just paper
How many
test.
tests? Like, I'm
11.
at 20, today's only 11. I
11,
was 21, I was gonna say 21.
Right.
It's a
11.
lot of tests from him. Megan.
Right, 11.
Okay.
So, since you're not part of the 0524 cohort, you're
Yeah.
022, 0522 or something like that. Whatever.
Yeah. And the finals are back then.
You open Tuesday, Thursdays, like an hour a year.
One? Yeah, probably.
Okay.
I'd probably do that. So
We have classes.
your class is 205. All right, yeah, Mason.
For those times that you have for us to come in, are we just able to take whatever test we're on? Or are you having specific tests?
You should be able to take whatever test, but I'll have to start each test separately and proctor each test separately, but it'll just show me a list that these people are taking this test, these people are taking this test, these people are taking this test. That's what the video said, essentially.
You're gonna have like 10 tests. I am so sorry.
Yeah, but the proctoring is the same.
Yeah.
The proctoring part is actually the same, but having to start letting students in for this one, students in for this one, students in for this one, that's usually not, that's not that hard. Right? Erica, you're looking very worried.
It's a lot.
It's fun. It's hard. That's the way it goes. And as you guys are well aware, I'm still learning ATI and the learning curve is pretty steep. So, all right, back to the ranch here. This is a drug called fondaparinux. Fondaparinux, it is on your handout and it's in the factor 10 inhibitors. This is a smaller molecule than low molecular weight heparin. So it is predominantly a factor 10 inhibitor. And it is used under certain circumstances that we'll get to in just a bit. So here's a nice comparison between unfractionated heparin and the low molecular weight heparin. And I think you can see the differences are pretty clear. So fondaparinux is used for deep vein thrombosis and for PE, both treatment and prophylaxis. It's also used for something called heparin-induced thrombocytopenia, or HIT, which is the biggest single danger zone when it comes to using heparin. Now, heparin-induced thrombocytopenia occurs when heparin binds to the surface of a platelet, and there's a protein on the surface of the platelet called PF4. PF4 and heparin form a complex, and the immune system recognizes that as foreign, and you start making antibodies to it. Those antibodies bind to the surfaces of platelets and they activate. So you get this mass activation of platelets. So you get clots all over the place and you exhaust all your platelets. That's called heparin-induced thrombocytopenia, or HIT. HIT. So you usually see it 5 to 14 days after heparin administration. This is a serious condition. It's a medical emergency. You get the antibodies to PF4. In fact, if you detect antibodies to PF4 in the blood, that's diagnostic for HIT. And they're a good test for anti-PF4 antibodies. You can order that test. DVT usually accompanies HIT. So with DVT, the limb is red and it's hot to the touch. It's painful. You have visibly large veins. When you touch them, they're warm because blood is backing up in them and it's inflamed. With a pulmonary embolism, the individual will have shortness of breath. There'll be a pretty sudden change in the heart rate. They'll have dizziness and they will have sharp chest pain, and I mean sharp. It hurts. Distal limb ischemia is also very common in HIT because you get these little clots and they travel to the small capillaries in the extremities. And so as you can see, I mean, this poor person here, a good chance this person is going to lose those toes. Have I convinced you this is serious? So again, you make IgG to PF4, you get PF4 heparin complexes on the platelets. There's an FC receptor that gets bound to the antibody that activates the platelets. And now the platelets get used up. So you have lots of clots, and then you don't have any platelets to initiate new clots. So you get the complex PF4, heparin, antibodies bind to it. They bind to the surface of the platelet. It binds the FC receptor, and you get the pathology associated with heparin-induced thrombocytopenia. Okay, brainstorm. Got a patient, had a hip replacement. They're on heparin. What are you gonna monitor to see if they have HIT? What are you gonna monitor? You can do a draw, but by looking at them, what are you gonna look for? You have to have a reason to do the draw. The reason to order the test. You just start ordering tests willy-nilly, your hospital administrator is going to get mad at you and accuse you of wasting hospital money.
They'll have platelets done every day though. And usually they'll pump thrombocytopenia.
Yeah, but that's you're that machine.
No, yeah, it'll be less than 150. And that's like given for a diagnosis and then they order the lab.
Yeah, except the platelets may go down gradually.
Yeah, that's just how
Sometimes it varies. It varies.
And then like below 50,000.
Oh, it is.
There's like different levels. So
Yeah.
below 50,000 and below.
Somebody's gonna get say DVT. What are you gonna look? You're gonna PE. That's PE. Good. So you're gonna listen to breathing. It's the breathing. The shorter breath. Pain when they breathe. That hurt? Okay, how about Emily? How about what are you gonna look for? No. Good, veins. What are you gonna look for in veins? Okay, Erica. Good. So you want to be pulling that blanket up and checking those legs. That hurt? Could you know, whatever. You know, and so on and so forth, and checking legs. Also, you want to be checking. So just do hand check, toe check, what have you. And as Clara reminded us, patient will be getting platelets every day. If the platelets start to take a dump, you can order anti-PF4 antibody tests. Haley, what do you think heart rate? What's their heart rate? Because they're going to be on a monitor.
Yeah.
What are you going to look for at the heart rate? If the heart rate abruptly changes, that might be an indication of a pulmonary embolism. That happens. You know, listen to their breathing, see if there's pain, inhalation, exhalation, give them a little tap. If they go, ouch, bad sign. Then you order the anti-PF4. How do you treat HIT? You can use fondaparinux. Fondaparinux is used off-label. The two drugs that are FDA approved for HIT are this drug, argatroban. Argatroban is a direct thrombin inhibitor. And then bivalirudin. Bivalirudin is a small molecule that actually comes from the salivary glands of leeches. So research on leeches has actually led to a pharmaceutical that is actually very useful for heparin-induced thrombocytopenia. So this is something to watch for if a patient is on heparin. Be doing those distal appendage checks and what have you. Those are all things to keep in mind. And if they're on unfractionated heparin, you're going to need to do these on a regular basis. Those activated partial thromboplastin tests. Very good. Let's talk about warfarin. Warfarin is taken orally. It's very rapidly and effectively absorbed from the GI tract. The absorption and the bioavailability is virtually 100%. It prevents the post-translational modification of clotting factors 2, 7, 9, and 10. Genetics affects the drug response. Diet affects the drug response, and the other drugs you're on affects the drug response. So the name of the game of warfarin is adjust, adjust, adjust. So warfarin is an indirect actor. Doesn't directly inhibit coagulation, it indirectly inhibits coagulation. It's a vitamin K antagonist. It prevents the formation of active forms of clotting factors 2, 7, 9, and 10. So here's how it works. So in your liver, you have these enzymes. You have the vitamin E epoxide reductase and the vitamin K dependent reductase. And the vitamin K epoxide reductase, VCOR, as you see there, that's the enzyme inhibited by warfarin. The gene that encodes VCOR is called VCORC1. This gene is very polymorphic. Some people make a gene product that is very heavily inhibited by warfarin. Others make a gene product that's a little resistant to warfarin. So genetics is going to affect how susceptible you are to warfarin. You can see that this vitamin K is changed and then it's regenerated. Warfarin essentially will inhibit the regeneration of vitamin K. Warfarin, as you can see here, inhibits these different factors, but these different factors have different half-lives. You have to inhibit all four of them in order to have proper anticoagulant activity. Therefore, warfarin is going to take 4 days to start working. Warfarin also inhibits the coagulation regulator protein C. Because of that, if you take warfarin without a bridging anticoagulant, you get warfarin-induced necrosis of the skin. You get clots in the skin because protein C has the shortest half-life out of all the others. So you always bridge someone with another anticoagulant, usually heparin, during those 4 days before warfarin comes online. Always. Always. You're confused? Warfarin takes 4 days to start working. Okay, bottom line. And you must always bridge someone with another anticoagulant during those 4 days, or they will get warfarin-induced necrosis of the skin. Warfarin is metabolized by predominantly cytochrome P450-2C9. Now, warfarin, as you can see, comes in a racemic mixture. The S stereoisomer is the more powerful one. The R stereoisomer does have some activity. That means that drugs that inhibit these particular, or maybe induce these particular cytochrome P450s are going to mess with warfarin activity. So warfarin is a long half-life, binds very tightly to serum proteins. The metabolism of warfarin varies from person to person because these cytochrome P450s vary in their activity from person to person. The dose will be affected by nutrition. You want someone to go on a special diet to take warfarin? Usually not. You ask them to eat normally, and then you dose the warfarin accordingly. However, there's certain high vitamin K foods they need to stay away from. Watercress, collard greens, Swiss chard, kale, Bree's looking at me as if to say all the things I don't eat and I've never heard of. Broccoli has a lot of vitamin K. Now, if you eat a little bit of broccoli, that's fine. If you eat a lot of broccoli, that's a lot of vitamin K. Yes, but many of those are cooked and they won't have quite as much vitamin K if they're cooked. Watercress, if you go to Great Britain, watercress is put in sandwiches. It's a green. It's a type of salad. So spinach has the highest vitamin K content per cup. It has 889 micrograms of vitamin K per cup. Mustard greens has an X, then collard greens, then beet greens, dandelion greens. Who eats dandelion greens? What are you, a cow?
They're good when you grill
Okay.
them. Okay, breathe.
Swiss chard is the next. Turnip greens, garden cress, kale, escarole, Brussels sprouts, broccoli, cabbage, endive. Endive is just simply lettuce. That's usually romaine lettuce, not iceberg. Pickles don't have that much, but they're on the list. Okra, green beans, really not that much. Celery, not that much. And fennel. Yeah. So those are the ones with the high. Now, when someone goes on warfarin, they'll be given a sheet that lists the foods they should probably stay away from. And since my mother ate a lot of those types of foods, she was crushed. Yes. You do adjust the dose. You adjust the dose. So also their liver function, their degree of biliary health, and their other drugs are on affect the dose too. So here is a really short list of drugs that interact with warfarin. So there are drugs that increase the activity of warfarin. There are drugs that decrease the activity of warfarin. So again, this is a short list. Some of them will do it pharmacokinetically. Some of them will do it pharmacodynamically. These are just some things to consider. Again, this is a very short list. I don't need you to know this. I just want you to know there are lots of drugs that interact with warfarin. So, which anticoagulant has the most drug-drug interactions? A, dabigatran, B, heparin, C, warfarin, D, fundaparinix, E, argatrovan. It's warfarin, hands down. The less severe side effects. Maddie, was your hand up? No, for some, okay. I think maybe I saw McKenna's computer or something. A lot of people who take warfarin tolerate it pretty well. It does tend to cause gas. Some people experience hair loss. A lot of guys who take it are going bald anyway. They don't care. Women, I think hair loss is kind of more of something they feel acutely. The biggest one you see is easy bruising and bleeding. The big worry with warfarin is intracranial bleeds. So if they bump their head or something like that, they need to get to the ED. You want to always, with people on warfarin, be watching for things like coffee ground type vomitus. That's dried blood, usually in the vomit. Lactary stools. You want to look for ecchymosis, bleeding under the skin, bruising. So I'll be checking essentially hands, they bruise very easily. Sometimes just actually leaning on something like this for an extended period of time can cause bleeding under the skin for people on warfarin. They have to be very careful brushing their teeth. Also shaving. Guys should not use regular razors. They should use an electric razor. They should also use a electric toothbrush with extra soft bristles. The companies that make the electric toothbrushes sell them. It's a lot of education for people on warfarin to just make sure you limit the amount of bleeding. Their nails, they need to be careful the way they do their nails. They need to make sure their nails are short so that they don't stab themselves, cut themselves with their nails. If they have a tendency when they sleep to whack themselves, they should wear their gloves they can buy to protect their hands when they sleep. There's just a lot of stuff because they bruise really easily. And if they bleed into joints, that's going to cause joint destruction. So, and if they're at risk for falls, that's a big danger sign. They need to minimize, do whatever they need to do to reduce their risk for falls. All right, now it's time to go. There's just one more thing I want to tell you about warfarin. So the test for warfarin is a prothrombin test. The problem with the prothrombin test is that the results vary depending upon the lab protocol you use and the reagents you use. So the prothrombin test time is standardized. You go to a book and you find the protocol you use and the results you use. Well, actually, you put it into the computer now. And you get this thing called an international normalized ratio, an INR. And the INR is the number you want. For someone on warfarin, it needs to be between 2 and 3. That's a lab number I need you to know. It needs to be between 2 and 3. The INR, international normalized ratio, for someone on warfarin needs to be between 2 and 3. If it's below 2, it's too low. They're at risk for a clot. If it's above 3, it's too high. They're at risk for bleeding out. Between 2 and 3, know that number. So before you go, how long does it take warfarin to start working? What do you do during those 4 days while they're on warfarin? Bridge them with another anticoagulant. What do you test to see if warfarin's working? INR. And the INR number needs to be between 2 and 3. How often do you test them? Every week. Every week. And you adjust as needed. All right. We'll finish this. We'll go to the antiplatelets, and then we'll look at drugs for anemia. You had a lot of the signs we talked about. Yeah.